Welcome to the Tobacco Online Policy Seminar, TOPS. Thank you for joining us today. I'm Justin White, a tobacco researcher at University of California, San Francisco. TOPS is organized by C. Shang from The Ohio State University, Catherine McLean from George Mason University, Mike Pesco at Georgia State University, and me. The seminar will be 1 hour with questions from the moderator and discussant. The audience may pose questions and comments in the Q&A panel, and the moderator will draw from these questions and comments in conversation with the presenter. Please review the guidelines on tobaccopolicy.org for acceptable comments. Please keep the comments professional and related to the research being discussed. Comments that meet the seminar series guidelines will be shared with the presenter afterwards, even if they're not read aloud. Your comments are very much appreciated. This presentation is being video recorded and will be made available along with presentation slides on the TOPS website, tobaccopolicy.org. I'll turn the presentation over to today's moderator, C. Shang from The Ohio State University, to introduce our speaker.
Today, we continue our 2023 season with a single paper presentation by Kevin Callison entitled Paid Sick Leave and Use of Clinical Smoking Cessation Tools. This presentation was selected via a competitive review process by submission through the TOPS website. Kevin Callison is an assistant professor in the Department of Health Policy and Management at the Tulane University School of Public Health and Tropical Medicine. He also had appointments in the Department of Economics and the Murphy Institute for Political Economy at Tulane. Dr. Callison's research primarily focuses on evaluating policy interventions that aim to improve population health, including issues related to health insurance, health service use. In addition, he conducts research on health behaviors, health determinants, and substance use. He is currently working on projects that assess the various impacts of Medicaid expansion in Louisiana and the relationship between paid sick leave and health. Dr. Mike Pesco is a co-author and will answer select questions in the Q&A. Our discussion today is Meredith Slopin, doctoral research assistant at Columbia University School of Social Work. Dr. Kevin Callison, thank you for presenting for us today.
Thanks, C, and thanks, Justin. I appreciate you having me, and I appreciate everyone attending, and especially appreciate Meredith for discussing today. So I am going to talk a bit about paid sick leave and the relationship between paid sick leave and clinical smoking cessation tools. So let me just, all right. Hopefully everyone can see the slides there. This is a project that I am collaborating with Mike Pesco and Serena Phillips, who are here and hosting us today, and with Julianne Sosa, who is a colleague in the Department of Surgery at UCSF School of Medicine. And well, the disclosures here, this is work that is funded by the National Cancer Institute. Of course, the content is our responsibility and doesn't reflect on the views of the NIH. This is part of a larger project that is examining links between paid sick leave and cancer prevention. And so I'll just mention a couple of things we're working on with the larger project. And today we'll focus on the smoking cessation component of this. So we really had two areas of focus with this. We were looking at the relationship between gaining paid sick leave coverage and cancer screenings, screenings for colorectal cancer and screening mammography. And then also asking whether gaining paid sick leave coverage could impact smoking cessation. And I'll talk about why we think that might be the case and some of the mechanisms that might be at play there. I also want to say that this is very much still a work in progress. So any thoughts or comments about how to improve this research would be welcome. So what we're going to do is use plausibly exogenous variation in paid sick leave coverage to estimate effects on screening mammography and colorectal cancer screening. That's part of the other project. I won't talk about those results today. Today, I'll focus on tobacco cessation counseling and prescriptions for cessation medications. And one of the things I'll say that I think one of the contributions of the work that we're doing is this idea that we're using plausibly exogenous variation in paid sick leave coverage. And you'll see what I mean by that when I talk about the landscape for paid sick leave. But I will say a lot of the work in this area that examines the relationship between paid sick leave coverage and health outcomes tends to compare people with and without paid sick leave. And, you know, of course, there are lots of differences between people who have and don't have paid sick leave, and some of those differences are likely to be unobservable, and some of those differences are likely to correlate with health outcomes. So we try and improve on this approach by using a recent development of paid sick leave mandates that require employers to provide paid sick leave coverage to their workers as sort of a plausibly exogenous approach that allows us to examine coverage gains in paid sick leave without just focusing on a simple comparison between those who do and don't have coverage. So I'll talk a minute about why we care, why we think this is important work. And then I'll get into the mechanisms that we think potentially link paid sick leave to smoking cessation. So the first thing to note is that, as I'm sure most of you are aware, that there is this relationship between income and tobacco use. The higher income, less likely you are to use tobacco. This is data from the NHIS that just shows this relationship over time, over our sample period here. And you can see that that households with lower income have higher tobacco use. And so when we think about paid sick leave, you know, in mandates that require employers to cover paid sick leave, in many cases, the benefits of those mandates are accruing to people at the lower end of the income distribution who also tend to have higher rates of tobacco use. So I'll come back to this in a minute, but let me give you some background on what paid sick leave looks like in the US and why these mandates are important. This is data from 2016, which is the mid-period of our sample period that we're going to study. And this shows the share of workers, of private sector workers who lack paid sick leave coverage. And you can see it was roughly 38, 37% of workers at this time who didn't have access to paid sick leave coverage, but there's this really strong relationship between income and the likelihood of lacking paid sick leave. So of course, workers at the lower end of the income distribution, these are quartiles of the income distribution. If you were in that bottom quartile of the income distribution in 2016, there was about a 60% likelihood that you did not have access to paid sick leave. This has changed some over time, like I said, because of these mandates that require employers to offer coverage to their workers. And there was a temporary change in 2020 with COVID that allowed some access to paid sick leave for reasons related to COVID that then expired at the end of 2020. And there's some work that's been done on that suggests that maybe that wasn't all that effective because, you know, people didn't necessarily know they had the coverage, they didn't know how to use the coverage. But we're focusing on a period that doesn't include the COVID paid sick leave. So I mentioned a couple times now that we are that our source of variation is going to come from these mandates that have recently been enacted at state level, the county level, the city level. There's some variation there in the jurisdiction of these mandates. But starting in, I think 2008, it was with San Francisco, then Washington, D.C., Connecticut, we've seen more and more municipalities enacting paid sick leave mandates. And I'm happy to answer questions about what the scope of these mandates tend to be, but I think for our purposes now, what's important is that these mandates require employers to provide paid sick leave coverage to their workers. That paid sick leave coverage can be used for preventive health services. So, you know, for example, when we were thinking about the cancer screening outcomes, it was important for us to realize that when you have paid sick leave, you can use that to, you know, go get a mammography, for example. That's an allowable use of paid sick leave in every case that a mandate has been passed. Some of these mandates on this picture actually didn't end up taking effect. So there are these 3 cities in Texas that had proposed paid sick leave mandates that a court in Texas invalidated. And some of these that I show you in the picture fall a bit outside of our sample window, but I'd be happy to provide more information on this as we go. So we're going to use variation in both in the timing of the adoption of these mandates and the places where the places that have mandates and the places that don't have mandates to look at the impact of this expansion of paid sick leave coverage. And this just shows you how many people are affected by these paid sick leave mandates over the period that we're going to examine. So this is one of those annoying graphs that has two y-axes. If you focus on the axis on the left, that's the annual gain in millions of people. So in 2015, there were about 8 million people that are estimated to have gained paid sick leave coverage because of these mandates. That primarily comes because of California passing a mandate in 2015. And then you see in 2016, 17, and 18, there was also additional growth from new mandates. The y-axis on the right-hand side and this dashed line are tracking cumulative gain over our sample period. So we end up with, by the end of our sample, more than 15 million people who have gained coverage over our sample period. Now, I think with some of the more recent mandates that have passed, that number's 21, 22 million people who are estimated to have gained paid sick leave coverage because of these mandates. Okay, so let me talk for a minute about the mechanisms why we think that paid sick leave coverage might impact smoking cessation. There's kind of a story here that I want to track each step of the way in the story to get us from paid sick leave to smoking cessation. So the first thing is that in an earlier paper, we examined changes in paid sick leave coverage associated with these mandates. So, the question here is like, when a municipality enacts a paid sick leave mandate, how many people actually gain coverage, right? Because in many cases, people already have paid sick leave in the absence of a mandate. In some cases, these mandates carved out specific populations that were exempt from the mandate. So, if you worked for a small firm, sometimes you're exempt. If you work in certain industries, you might be exempt from these mandates. So the first step was really to quantify how big of an effect these mandates have on coverage. This is a picture from a study that we conducted to do that. And you can see that there's an increase here, the relative increase, depending on the specification and which groups you focus on, is somewhere between around 28 to 45% increase in the share of private sector workers who report they have paid sick leave coverage after a mandate is enacted. So we do see a pretty sizable gain in coverage following these mandates. We also find some evidence, although this is a bit noisier and given data limitations, this is just a more difficult outcome to analyze, but we do find some evidence that not only do these mandates increase coverage, but they increase absenteeism, work absenteeism. Here, the range is much bigger. It's a 20 to 62% increase. And the reason that range is so big is because the magnitude of the relationship between paid sick leave and absenteeism really depends on how you're defining absenteeism. So if you ask people, did you miss work because of an own illness, because you were sick and you had paid sick leave that covered that absence, that's a fairly low rate here, given the data that we used in this study. But it turns out if people have kids and their kids are sick, you see much higher use rates of paid sick leave. So we tried to establish the fact that paid sick leave mandates improve coverage, and that improved coverage does lead to some the people using their coverage and taking time off work when they're sick. So then to finish off this mechanism story, the next part of this was, well, if people are gaining coverage and they're missing work because they're sick and they now have the ability to get paid if they are sick, are they interacting more with healthcare providers? Are they going to the doctor more? And this is some evidence that is from a paper that we're still working on, but uses the same data that I'm going to present today, and does find some evidence of increased physician visits resulting from paid sick leave. So, now we see people gain coverage, we see people miss work and use their paid sick leave, and then we see some increase in interactions with providers. And I think this is really where the story comes together with smoking cessation or tobacco cessation and paid sick leave. So, the idea we have in mind is that if you're a tobacco user and you're going to the doctor more frequently now because you have paid sick leave, that's additional opportunity for the provider to counsel you on tobacco cessation, or to prescribe medication for you to, to assist with tobacco cessation. So we do think that the story holds here. Now, whether or not this actually leads to reduced use of clinical cessation tools, that's what we want to investigate today. So I want to stop there and see if there are any questions at this point on the background or the motivation before I go into the data and the research strategy.
Thank you, Kevin. So let's turn to Meredith first, whether she has any comments.
Thank you. And thank you so much, Kevin, for talking us through what's a very exciting study. I really think that the examination of non-health policies like sick leave to understand how they can improve health are really key to addressing health disparities and poor outcomes, because the disparities in access to sick leave overlap so strongly with health disparities. And you show that really well in thinking about who are the people who, despite years of smoking cessation programs, continue to remain as smokers and tobacco users. I think one question that comes up for me in this is really thinking through more of the heterogeneity of the population of smokers, and thinking specifically, as well as the heterogeneity in the people who don't have access to sick leave. And as you mentioned when you were discussing the policies, I'm curious about the demographic profile of California with respect to race and smoking patterns among the Latinx population there in particular, given that in studies that we've conducted in New York City, even after the passage of mandates, we see low uptake rates or knowledge of access to sick leave following the implementation of policies. And so I'm curious how you're thinking about that population in your work. I also really appreciated the first paper on cancer screenings. And so I think that this is sort of the next stage. It's like the prevention aspect that you would then expect to see come up in the cancer screenings. And so I'm very excited about those aspects of the work and this convergence on risk populations.
Yeah,
I think at the end, sorry, go ahead.
No, sorry, go ahead.
No,
please.
it's fine. I'll hold the next one.
Okay, well, yeah, just to the comment on heterogeneity, I think that's a great comment. And I think, that as you'll see with the data that we use, we're looking at this geographic level at the metropolitan statistical area, because that's what the data require us to do. And we're looking at these MSAs that are exposed to paid sick leave mandates. That's kind of our treatment group, and the MSAs that aren't exposed are our control group. And you're right that when California passes their mandate, that generates a lot of variation for our identification strategy, because a lot of our MSAs that are being exposed to paid sick leave are in California. And, of course, California looks very different than other places in the country. And that's something that we really haven't done a lot of work on at this point, is examining that heterogeneity across different places that are adopting mandates. I will say that for the cancer screening paper, we provided a kind of a supplementary analysis where we estimated effects individually for each MSA, and then created a plot of what those effects looked like. And it is very heterogeneous in terms of effect sizes. And I think part of that is due to the difference in the demographics, the populations that are being affected. Part of it's probably due to the scope of the laws that are being passed. So in some places like California, they're very all-encompassing, and other places they carve out a lot of people from the law. And so, the thinking about how each policy differs in terms of the groups that they cover, I think is important also. So I agree that that's critical, and I think we need to continue to do more work in that area.
Thanks. I think like I said, I think this is very exciting. And I think that the end of the mechanism story of seeing the increase in provider visits is very consistent with other studies from Zhang et al. And the Cohen Gleed paper that show an increase in health services use. And so I'm excited for the next section where we'll see if this increase in provider visits leads to increases in prescription smoking cessation. I guess the other thing in terms of heterogeneity is just, if you're able to, and maybe you'll get into this, account for local or state smoking cessation efforts outside of the prescription environment that were happening simultaneously. And so thinking about, through the early to mid 2000s, there was a lot of restrictions that were put on smoking on advertising on tobacco sales. And those also varied by location. And so is the other thing that I was thinking about in terms of isolating the impact of sick leave. But I'll leave it there for now and see.
Yeah,
what's next.
that's a great point. I'll come back to that as we go through the results. I appreciate that. All right.
Okay, so why don't we continue?
Okay.
Yeah, thanks.
Okay, so I'll spend some time talking about our data and the research strategy that we use here. Our data come from what used to be called the IBM Market Scan Commercial Claims and Encounter Database. Actually used to be called Truven, then IBM, and now Meritas Market Scan Commercial Claims and Encounters Database. We have data from 2011 to 2019, but the way we define our outcomes with a 12-month look-back period. So in other words, did you have tobacco cessation counseling, a claim for tobacco cessation counseling within the past 12 months? And so because of that, really 2012 is the beginning of our analysis period. We look for claims with diagnosis or procedure codes for tobacco use, both history of tobacco use and current tobacco use, and then we look at cessation counseling and prescription cessation medications. We're really, primarily interested in these cessation tools like counseling and cessation medications, but we also want to be aware of the fact that smoking rates could be changing, and so we're doing some work with the diagnosis codes on that. We make some sample restrictions to our data because we want to focus on a group of people who have a high likelihood of smoking. And we discussed several ways to think about how to identify this group. What we probably would not want to do is identify our sample based on the diagnosis codes in the claims data, again, because those could be changing with paid sick leave. So ideally, we want to focus on a group of smokers and see how their behaviors change when they gain paid sick leave. We can't really do that because we have claims data. We don't know who smokes and who doesn't other than through the diagnosis codes. So what we do instead is we focus on a population from our claims data who has a high propensity for tobacco use. And the way we determined who this group would be is we use data from the NHIS to identify subgroups based on characteristics that were observable to us in the claims data that had high rates of tobacco use. And it turns out that for us, those people are between the ages of 40 and 59. They're hourly workers. So we know that in the claims data, whether they work for an employer and are paid hourly. And they are employed in these three industries: agriculture, forestry, fishing, construction, manufacturing and durable goods, and oil and gas extraction and mining. So I guess 4 industries there, or 4 industry categories. And again, we require them to have continuous plan enrollment for 12 months. So anybody who we see them enrolled in a plan and then say they drop out for a couple of months and then come back in or shift to a different plan, we drop them from our sample because we can't observe all of their claims over that 12-month period, and we don't want to miss any cases where they might be getting counseling or cessation medication. So going back to this picture of smoking rates by income, I've added this red line, which is our target sample here. So if by making these sample restrictions, we end up with a population that is much more likely to be tobacco users than even if we just focus on income alone. So you can see that somewhere between 25 and 30% of our people in this sample of private sector workers are likely to be tobacco users. And so this is the sample that we're going to focus on when we look at the impact of paid sick leave on these clinical smoking cessation tools. Okay, so when we do this in the claims data, we end up, after these restrictions, with a population of about 1.15 million person years. We aggregate this up from the individual person level to the MSA by state level. And again, I said we have to use the metropolitan statistical area because that's the finest level of geography that's available to us in the market scan claims data. This isn't perfect because there are, there aren't these paid sick leave mandates are not focused at the MSA level. They're focused at the state level or the city level or the county level. And so in the case where it's a state mandate, that's pretty easy. If the MSA falls entirely in that state, then we consider everyone to be exposed to that mandate. But there are cases where, it might be a city mandate and the MSA goes beyond the city boundaries. And so we do a few things to try and adjust for that. Basically, we end up defining our paid sick leave exposure mandate as the share of the MSA population that is exposed based on the level or the jurisdiction of the mandate. So either county or city, if it's not a state mandate. So we end up with 292 MSA by state units that are in our sample over the 8-year period. And after we aggregate up, we have 2,336 observations. We estimate a difference in differences model here to compare changes in the use of these cessation tools among people in MSAs that were exposed to a paid sick leave mandate and compare those to people in MSAs that were not exposed to a mandate. We control for some time varying characteristics here. To Meredith's point, one thing that we have not controlled for yet, although we absolutely need to do this, are changes in policies like cigarette taxes and smoking bans. We have that data. The results I'm showing you today don't include those as controls, although that's something we absolutely need to control for in our regressions here. And then we do two different types of, two different estimation strategies. The first is a two-way fixed effects estimation strategy. I imagine many of you know now that when we have a staggered treatment timing situation like we do here with municipalities adopting mandates at different times, Andrew Goodman-Bacon and others have recently pointed out that there could be some bias associated with the comparisons that happen in a two-way fixed effects estimation strategy with staggered treatment timing. So we use Goodman-Bacon's decomposition tool to diagnose the potential extent of this problem in our case. Turns out it's these comparisons of potential comparisons across treatment timing, so comparing late adopters to early adopters or vice versa, makes up a fairly small component of our difference in differences estimate. That's because, as I showed you before, we've got a big bulk of MSAs that are being exposed in the middle of our sample period in 2016 when California adopts. So most of the weight on our difference in differences estimate is coming from comparisons of exposed to unexposed MSAs. That being said, we still do a correction, the Callaway and Santana method, to try and address potential bias from the two-way fixed effects. Although, as I'll show you, in most cases, it doesn't make too much of a difference because of that small weight that's associated with the treatment timing comparisons. And then we cluster our standard errors at the state level. Okay, I thought I'd stop again here just to see if there were any questions about data, methodology, anything there.
Thank you, Kevin. So again, let's turn to Meredith first to see whether there's any questions. Thank you.
Great, thanks again. I really appreciate the use of commercial claims data. I feel like especially for stigmatized behavior like smoking, it does a nice job of reducing reporting bias. And I also really appreciate the sample restrictions, thinking about the overlap between paid sick leave and smoking and who we would expect to be most impacted by mandates with respect to smoking cessation behavior. I think you remove a lot of the noise. One question that I had with respect to the industries that you selected is I'd love to know more why you're not including the service sector industry where we have low levels of sick leave. I know that some policies exclude fast food workers, for example, in Seattle, and other things and so that might be it, but I was hoping you could speak a little bit more about that.
Yeah, that's a great question. And I think if I remember correctly, the market scan data has 9 different categories, 9 or 10 different categories, maybe it's 10 of industries that correspond to, you can kind of crosswalk those to industries in the NHIS where we were looking at smoking rates by industry. And one of the things we did is we were narrowing this population of people who had high rates of tobacco use was sort of sort by the industries that had the highest rates. And so those industries, I'll just go back so we can see which they are. These were the industries that had the highest rates of tobacco use. And then there was kind of a break in the propensity to use tobacco as you move to the industries that followed that. So I agree that service industry is probably one of the top industries to be impacted by paid sick leave mandates, but actually compared to the industries we included here, had lower rates of tobacco use.
Thank you. That's really helpful. I have one more question about your clustering of standard errors at the state level.
Yep.
And I was curious why you were clustering there instead of at the MSA level, given that you're including some of the local policies in addition to the state level policies.
Yeah, no, that's a great question. I think it would be the conservative approach to cluster at the state level rather than the MSA level, because you could imagine there could still be, like, I keep using California as an example, but it's a good example here that when California passes the state law and a bunch of MSAs in our data within California are impacted by the policy, you could imagine that there could be some correlation in the error terms across those MSAs within the state of California, because they're also exposed to the different policy environment that California has from other states. And so I think the more conservative approach here is to consider that to be a possibility and cluster at the state level.
Thanks. That's all I have for now.
Thank you. We have one audience question from Christian Science, and this question is related to Meredith's last point about industry. So she asked, why not include accommodation, food services, and industry, which has a high smoking rate? I thought you already answered a part of this, but I would be curious that whether you have calculated the smoking rate for this particular segment of accommodation and food services. Can you do that?
Yeah, I can't remember.
Yeah.
So again, the categories don't align exactly with the more detailed industry categories that are available in the NHIS. These are kind of rolled up to the higher level industry categories. I can't remember if that is a specific category that we have separate from, say, the service industry. But again, what we did is just really look at each industry that we have available and calculate the smoking rate, or tobacco use rates rather, in each of those industries, and then focus where there was kind of a natural break in the higher rates of tobacco use industries. And so these were the top industries where, in terms of tobacco use. Yeah. But of course, we could easily experiment with including other industries or eliminating other industries. The trade-off here that we're sort of facing is we have a lot of data, so that's great, but the more industries we exclude, the less data we have, but the higher tobacco use rates we have, right? So we face a little bit of a trade-off there, but I do think it would be reasonable for us to experiment with different industries and look at different effect sizes there.
So there's another question from Christian. So the age group you choose probably is experiencing some tobacco-related health problems at that point in their life. Can you in younger ages who also smoke but haven't accrued the health complications yet? So this is about the sample restrictions where you reach the age to 40 to 59. Yeah.
Yeah, so there's two answers to this question. One is more practical than the other. So the first answer I'd say is, again, we looked at ages that had the highest rates of smoking and in the NHIS, and this was the age band that had the highest rate. And I keep saying smoking, but I mean tobacco use. And so we restricted it to this. The more practical reason is because this project also involved cancer screening, and we had something of a limited budget to buy the very expensive commercial claims data. We focused on a group of people who are 40 and older for the project, because it didn't make sense for us to include younger people for the other screening outcomes that we analyzed. Because screening is not recommended for people below age 40. So that was the practical reason for choosing the age range. But this is also the age range that does have the highest rates of tobacco use. So I hope that
Yeah,
answers.
it was, yes, it would be a future research idea, I think. Thank you very
Yeah.
much. I don't see, yeah, I don't see any open questions, so please continue. Thank you.
Okay, thanks. Okay, so some quick baseline descriptives on tobacco diagnosis codes and cessation tools. So interestingly, and I like, maybe this is not a surprise to most people, but you see that if we were to look at indicators for tobacco use in the claims data, whether you had a diagnosis code that indicated current tobacco use in the past year, or whether you had that code plus a code indicating a history of tobacco dependence, you can see it's a fairly small share of the data here. So even though the NHIS would tell us that, you know, based on the sample restrictions we made, we should see somewhere between 25 and 30% of these people using tobacco, we see much lower rates of tobacco diagnosis in the claims data. And there is some discrepancy between those in MSAs that were exposed to a mandate and those in MSAs that were not. Again, this could be, to Meredith's point before, like, you know, this could be a function of California having a lot of MSAs that are exposed to paid sick leave mandates and having a relatively low smoking rate or tobacco use rate compared to the rest of the country. We also find fairly low rates of cessation counseling. Again, I don't think this is probably a surprise to anyone, but 1% to 1.5% of our sample is getting cessation counseling in the past year. And somewhere between 3 and 4.5% of our sample is getting or filling a prescription for smoking cessation medication. Okay, so here are our results. These are event study results from our difference in differences models using the 4 outcomes: past year diagnosis, diagnosis plus history of dependence, cessation counseling, and prescription medication. And in 3 of these outcomes, we have some real problems here for our difference in differences analysis. There's these very clear pre-period trends that continue into the post-period that show, relative to our control group, our treatment group of those MSAs that were exposed to a mandate see declining tobacco diagnoses, declining diagnoses and history of dependence, and declining rates of cessation counseling. So, you know, those of you familiar with the methods would understand that this violates the parallel trends assumption, or at least provides evidence that that assumption is violated in our difference in differences models. So we have some issues here. We tried a few things to address these issues. We did do a propensity score matching exercise, which we also did in our analysis of cancer screening. That didn't really help solve our pre-trends issue here. What we settled on doing is a technique that is, I would say, maybe a more recent modification of including like a group specific time trend in your estimate. For our, skip this and talk more about this method. For our outcomes that showed some sign of pre-trends, we estimated that pre-trend. So we estimated a continuous linear trend using just the pre-period data. And then we projected that pre-period trend into the post-period and subtracted that trend off of our outcomes. So another way to think about this is that we more or less rotated this event study picture around that pre-trend, or that trend that was estimated using the pre-period data. So those of you who are familiar with the literature on this, there's a Mir and West paper in JHR that they talk about this with an example in the minimum wage. Andrew Goodman-Bacon has a paper on Medicaid where he does this technique. So a way for us to kind of deal with this issue of non-parallel pre-trends and estimate our difference in differences models. I don't think it'll come as a surprise when you look at these pictures that once we do this adjustment, we basically find no effects on tobacco diagnosis or cessation counseling. It's pretty flat through the post period there after a mandate is enacted. So I should have mentioned this. Our x-axis here is years from mandate enactment. We center all these around the period the year before a mandate was enacted in an MSA. And so you can see for 3 of these outcomes, there's really not much at all going on. Interestingly, for the 4th outcome, cessation prescription fills, it's actually falling in areas that are passing paid sick leave mandates relative to those areas that aren't. So we've got a negative impact on cessation medication. And, one of the stories that maybe makes sense if you were to see an effect like that is that, well, maybe people are quitting smoking after they're getting exposed to these additional provider visits and additional cessation medications, but we don't see that, at least in terms of the claims for diagnosis codes for tobacco cessation. And I don't have the results to present today, but we've done some work in the BRFSS looking at changes in smoking rates, reported smoking rates associated with paid sick leave mandates, and we don't see a lot happening there either. So I would love to hear thoughts on maybe what might be happening with the change in cessation prescription fills, because I don't think we yet have a good grasp on why we might be seeing a negative effect here. Just to put some numbers to these event studies. So if we estimate the difference in difference models and we average across the post period here in our event studies, we do see a statistically significant impact on cessation medications. It's about a 0.7 percentage point reduction. I'll tell you what that means in terms of relative effects here in just a second, but you can see that's the only outcome where we find a statistically significant impact of paid sick leave mandates. This picture is just taking the coefficients from each of our models, both our two-way fixed effects estimation coefficients and our Callaway and Santana estimation coefficients, and just plotting these so you can see the difference based on the estimation strategy that we use. For most of our outcomes, there's not too much of a difference. Again, we probably didn't expect there to be because there's relatively little weight going to the treatment timing comparisons. More of a difference for the cessation prescription medication outcome, although the coefficient estimates aren't too different there. And then to give you some sense of how these absolute effects translate into relative changes, these are the changes relative to the baseline rates for each of these. And again, you'll see not much happening with diagnosis of tobacco use. The counseling estimates, even though they're not statistically significant, the relative impacts are pretty large because the means here are really small. And so even relatively small absolute effects turn into big relative effects for counseling and cessation. So I'll wrap up here, and I'm happy to talk more about these estimates and what they mean, but our conclusion here is that that we do see some increase in physician visits and exposure to providers associated with paid sick leave, but we don't see that translate into changes in the use of clinical cessation tools for tobacco cessation, with maybe the potential exception of this negative effect on prescription medication for tobacco cessation use. A couple of next steps, I think, as Meredith mentioned, controlling for the changes in smoking related policies and taxes, we absolutely need to do that. We have some Nielsen retail scanner data, so it may be the case that people are using nicotine replacement therapy that they're buying over the counter and it's not prescription medication. We can check that, and we'll do that with the Nielsen data. And then I think some more work, as Meredith has suggested, around how much of this effect is being driven by California versus other places. That's another next step that we need to do here. But I'll end there so we have time for other questions. And again, I just appreciate everyone attending today and excited to talk about the work.
Thank you, Kevin. Very interesting. Again, let's turn to Meredith first to see whether she has some final comments and questions.
Yeah, so thank you so much, Kevin. I think this is such a great and important study to really think about how to clarify the areas of focus to increase access to medically provider-led cessation as compared to some of the other options that people have available in the community. I think that you're finding, as I mentioned earlier, that paid sick leave increases physicians' visits feels really consistent. But what we're seeing is that physicians aren't picking up the ball from there, is how I think we're interpreting the lack of significant change in provision of cessation interventions at that point. As a social worker, I feel like I'd be remiss not to wonder about non-physician providers and their role in this area, and thinking about about sort of the broader ecosystem around smoking cessation in general. I'm also curious if, and I don't know enough about the medically provided smoking cessation interventions, do these interventions require follow-up appointments? If they do, I think paid sick leave mandates would continue to provide a role in ensuring that workers who are smoking are able to engage in ongoing treatment efforts. And I think if it's a failure of providers to follow standards, it's the role of sick leave in smoking cessation still remains a little less clear, but there are other agencies and professional organizations to involve. And so I think this is all really important when we're thinking about how do we ensure that workers have access to smoking cessation treatment and the support that they need in order to engage in these efforts. One thought that I had on why you're seeing the prescription rate going down is I was curious about, you know, in addition to controlling for some of the policies, even just thinking about a control, adding a control for the MSA or state year smoking rates. If overall smoking is in decline, then the need for prescriptions or the demand for smoking cessation would go down, and maybe netting that out would be helpful there. And then finally, I'd love to hear your thoughts on and how the study team is thinking about the implications and recommendations that are stemming from the findings that you shared, because I think they're really helpful from a public health perspective in thinking through how to support smoking cessation more broadly. But thank you so much for this paper and the opportunity to discuss it. It was really great to learn from your work.
Yeah, thank you. I really appreciate the comments. And you know, going through a couple of these, the non-physician providers, I think is a really interesting angle to think about. For us, if it generates a claim, we see it, but if it doesn't generate a claim, we don't see it. And so, Meredith, you and I had talked before about how there might be efforts outside of you know, physicians. Certain, you talked about New York providing cessation devices and tools. That of course we wouldn't pick up in the data. So if there are these campaigns to reduce smoking or tobacco use are ongoing and concurrent with these paid sick leave policies, that's something that we're not going to pick up here. The point about requiring follow-up. So when we look at the provider, the change in provider visits, we do both an extensive and intensive margin analysis here. So is it the case that you're more likely to have any provider visit? And it turns out, yeah, that is true. It does increase the extensive margin of provider visits. There's also a small, not as large, but also a small increase in the average number of provider visits after paid sick leave, conditional on having any provider visit. So whether this is follow-up specifically for like a smoking cessation encounter, I think that's unlikely, but it does provide more opportunities for that counseling to take place, I think, or for that prescription to be written, because you are more likely not only to go to the doctor at all, but you're more likely to have an additional, slightly higher number of annual physician visits with paid sick leave. So I do think there are opportunities for that. And then the implications here, you know, I agree with you that, well, I think that probably people who have worked in this area for a long time would also say that things like counseling, that tobacco counseling, even though providers are supposed to do it, even though it's a USPSTF recommendation for tobacco users, it probably doesn't get done nearly as often as it should. And I mean, we see that at least in the claims. Now, whether the doctor's saying to patients, oh, well, you should really stop smoking, but then there's no claim filed for that. I mean, that absolutely could be true. So in that case, there might be some additional attempts going on to try and address tobacco use that maybe we don't see in our data. But I do think that, you know, that given the guidelines, if someone comes in and the doctor determines they're a tobacco user, there should be counseling taking place. In some cases, there should be maybe a prescription for tobacco cessation. And maybe this is thinking about the implications of this could be that maybe that, you know, the doctors aren't incentivized to do this through the reimbursement mechanism that comes from providing tobacco cessation counseling. So I think there's maybe some work to do there as well. You know, I do think we need to do some of these robustness checks and sensitivity analyses that you suggested before. I want to come down too hard on that this stuff just isn't happening and that there's no relationship with paid sick leave here. So, but I do think that's the direction that this is going in terms of implications, is that maybe we want to provide greater incentives for providers to intervene amongst their patients who use tobacco.
Thank you, Kevin. We have a few audience questions. One is from Elena. Do you think this is impacted by the family doctor shortage? So, I mean, I think this is asking whether your results are impacted by the shortage of family doctors.
Yeah, I think that's a great point. So one of the things that we're not able to do with the data, unfortunately, is examine urban rural differences in depth, where I think, if we're concerned about provider shortage and access to providers, then we might think that might be exacerbated in rural areas due to the shortage. Like I said, the data that we have are people who live in MSAs, which by definition are, these metro areas with a center county of at least 50,000 people or something like that. There's certainly variation in terms of the size of our MSA, so we could look at like bigger places versus smaller places, but I don't think we really have the opportunity here with our data to focus on rural populations compared to urban populations, which I think would allow us to do more work on potentially the role of physician shortages. So yeah, I unfortunately don't have a lot to say about that we can look at specifically in our data, but I think it absolutely could be an issue that could be limiting access to providers for people who live in areas that are especially impacted by these shortages.
Thank you. And a question from Christian Sanas again. Do you find small effects because employees are quitting by using nicotine pouches or vaping product as opposed to cessation with a healthcare provider? Could you get at this definitively with another data set?
Yeah, that's a great point. And we hope to do some of that with the Nielsen retail scanner data to see, who might be, whether there are changes in behaviors of purchasing over the counter nicotine replacement therapy and cessation devices. I think we could also, the vaping is a great point. And I'm sure my co-author Mike would know more about this than I would, about what data would be good to use to look at also changes. And not only, like I said, with the Burfus data, I think Sarita might be able to remind me, we might have done some work around vaping there too, but I'm not sure how frequently that or when that data becomes available in Burfus, but we should absolutely look to see if there's some substitution to vaping happening. So hopefully we'll be able to address some of that with the Nielsen data and maybe some attempts to look at substitution to vaping.
Thank you. I don't see any other open questions and we are about time. So I'll pass this on to Justin to walk us out. Thank you. Thank you, Kevin, for the great presentation.
Thank you.
Okay, we're out of time. Thank you to our presenter, moderator, and discussant. Finally, thank you to the audience of 120 people for your participation. Have a top-notch weekend.